Making the Rounds lecture series, and today's topic is otolaryngology care during a pandemic with Banner University Medicine's Department of Otolaryngology, Dr. Eugene Chang, Dr. Helen Yip, and Dr. Stephen Wang.
Hi, my name is Helena Yip, and I'm a laryngologist here at Banner Tucson in the Department of Otolaryngology and Head and Neck Surgery. My interests include airway management, voice and swallowing, and I'm very happy to be given the opportunity today to meet all of you and to speak on shortness of breath after COVID-19. As our country enters possibly the waning stages of the pandemic, the ravages of COVID are actually still emerging in these patients who have had infection. And I'm now part of the Center for Excellence in Post-COVID Care here in Banner, Tucson, and I see patients for specifically shortness of breath after COVID. So when a patient comes in for dyspnea, it's all about surveying the entire upper airway, spanning from the glottis, where the vocal cords are, to the subglottis, the region below the vocal cords, and then the trachea. Now, here's a video of a normal person in quiet respiration. And I just want to point out to you that the vocal cords are slightly pulled apart in quiet respiration. These lines represent the vocal cords, and then the red represent the cartilages. They're called the arytenoid cartilages. And you can see how there is a natural triangular shape in the glottis, which is a space between the vocal cords, when one is quietly breathing. Now, when you take a deep breath, the vocal cords actually pull farther apart. And this is illustrated in this video here, which I'll play for you. You can see how the vocal cords are now pulling far apart on forceful inhalation. And again, okay. So when one is exhaling, they come slightly back together towards the midline. Okay, so next, this is an illustration of an abnormal breathing pattern called vocal cord dysfunction. The other name for it is actually called paradoxical vocal fold movement, and you'll see in this video how the vocal cords actually come together during inhalation, which is not what you want because that severely restricts the airway. So let me play for you. So the opening shot here shows the vocal cords slightly pulled apart, and then when the patient's given instruction to deeply inhale, you'll see the vocal cords coming together. So inhale, they're coming together, and then exhale, inhale, see they came together again. As you can imagine, this creates a very severe sense of shortness of breath. These patients are often misdiagnosed as having severe asthma, and yet all their pulmonary workup will be completely negative, including pulmonary function tests, CT of the chest, and these patients could be treated with a ton of inhaled steroids and systemic steroids with no effect whatsoever. So I do see these patients after they've had a negative pulmonary workup. This condition is often delayed in terms of the diagnosis, and the primary treatment, in fact, is speech therapy. It is a form of laryngeal hypersensitivity. We don't exactly know how it comes about. Sometimes it can just come about because of prior manipulation or irritation of the airway. So certainly intubation could do it. And then industrial exposure or just a bout of severe cough could do it. So the mainstay of treatment is speech therapy. Now, what is speech therapy? It's actually nothing to do with speech. They're actually breathing exercises that the speech therapist will teach to the patient. It's quite miraculous because you're turning these patients from someone who's severely short of breath to someone who's functioning again and returning to society. And not every single speech therapist is familiar with these techniques. We have two speech therapists here, Dory Smith and Natalie Monahan, We're very fortunate to have them as part of our department. They are also on the faculty in University of Arizona in the Department of Speech and Language Pathology. They have a large airway practice. So together, we make a good team in managing these patients. Next, we'll move on to dyspnea caused by intubation-related injuries. Here's a top-down view of the larynx. What I want to illustrate here mainly is that the arytenoid cartilages, which are hooked onto the vocal cords posteriorly in the larynx, they sit on top of the cricoid cartilage. And here's an anterior view of the larynx, where again you see the cricoid cartilage, and then here is the thyroid cartilage, and this is traditionally what we call the Adam's apple. And then faintly you can see the outline of the arytenoid cartilages, which are hidden from normal view when you look at the patient from the front. I just want to point out to you how fragile these arytenoid cartilages are. You can see how they sit on top of the cricoid cartilage and they move apart to move the vocal cords apart, and they come together to bring the vocal cords together. And then you can see how they're particularly vulnerable during an intubation where the endotracheal tube is sliding down the airway. It's very easy to knock the arytenoid cartilage loose so they can become dislocated, or you can simply just scar this joint, which will then lead to ankylosis, which simply means freezing of the joint. If one vocal cord is scarred, or if one arytenoid cartilage is scarred to the underlying cricoid cartilage, you get what's called an immobile vocal cord. It's very obvious on initial view of the larynx. The paralyzed or the immobile vocal cord will be shorter in length, and it will also be more lax in terms of the tone. A fully functioning vocal cord will be nice and taut and of a normal length. And here's a video illustrating what an immobile vocal cord looks like. Mainly, I just want you to appreciate how when the vocal folds come together, there's a gap. And it's this gap that will make people very, very short of breath. The reason is whenever we want to bear down and exert ourselves, you need to be able to close the vocal cords completely. That's what allows us to grunt and to exert ourselves. If we lose that closure, that's where you leak a lot of air, and that'll lead to maybe spending a patient will have to spend 3 times as much energy to speak or to do any normal activities. As you can imagine, this will lead to people feeling very winded when they speak, or just feeling like they can hardly do anything. So the treatment for this condition is actually readily available in the form of an office injection. This is done in an awake patient. I have an assistant holding the flexible laryngoscope, and I'm actually coming in with a very long injector needle through the mouth. And you can see how here the patient is nicely numb and he's cooperative. You can see the needle entering the paralyzed or immobile vocal cord. Once the injectable material goes in, there will be a nice bulge in the vocal cord that you can see. And then I'll ask the patient to phonate, and that's how I gauge whether or not enough injectable has been injected. You probably won't be able to see the actual, you won't be able to hear the phonation all that well here, but I'll ask the patient to say 1, 2, 3, and he'll do so. It'll be the first time that he's speaking after many months.
Can you try saying 1, 2, 3?
1, 2, 3. The voice sounds good.
Okay. 1, 2, 3.
1, 2, 3.
Oh my gosh. Yeah. Okay.
So in instances where we're not sure if the immobility or paralysis is permanent, this is what we do. And the injectable material here lasts anywhere from 4 to 9 months. Once we're certain that the motion is not going to return, I actually take the patient to the operating room to perform a permanent medialization, which is done by creating a window here in the thyroid lamina. and then I can then push in a silicone implant. The whole idea is to mechanically shift the vocal cord over. There's no real way to restore the nerve input to the immobile vocal cord. Another way to do it is to stack this ribbon material into the window. This is more adjustable, obviously, than a solid implant, and it works very nicely for a small defect. Now, if both arytenoid cartilages are injured, then it actually leads to a very severe airway issue. Patients where both arytenoids are scarred together, as you can see here, they hardly have an airway. So here you can see how the patient is actually breathing through just a tiny slit. And on inspiration, the slit-like airway gets smaller. And on expiration, on exhalation, it gets slightly larger. It's hard to believe that this is a patient who walked into my office and have been living like this for a number of months. He's not in extreme distress, he's uncomfortable. So in this situation, I have two options. I could either do a trach, which nobody likes, but in order to safely perform any kind of airway procedure, obviously a secure airway is the best way to go. Now, sometimes I do push the envelope and I don't automatically trach these patients. I take them to the OR and perform what's called a posterior transverse chordotomy. So I just cut the vocal cord posteriorly to create a triangular wedge. And amazingly, any increase in this glottic airway will lead to a significant increase in airflow. So my goal is never to restore it to a normal person's airway, but if I could just give them a little bit more of an opening in the back of the vocal cords where it's used more for breathing and not for phonation, then that may be enough to get the patient back to a semi-functional level. So this is a video, an intra-op video of someone with a right vocal cord chordotomy being undertaken right now. And it's done with what's called a co-blader, which has very little thermal damage, as easily performed. You can see how there isn't a whole lot of charring. So I'm going to speed through this in the interest of time, and then just let you see what the final cut kind of looks like. So I'm going to carry this out very laterally, and I can certainly do more inferiorly too. And this goes on for a little while longer. And it may look like kind of a war zone at the end, but let me show you the 1 month post-op video and how this patient now has a nice open glottic airway. And in fact, by untethering the vocal cord from the scar posteriorly, now you're seeing some mobility restored. The nerve input was not lost. It was just that the two vocal cords simply couldn't move because they were scarred together. So this patient was very happy. Now we'll move on to subglottic and tracheal injuries. Now, how is the trachea injured with intubation? It is from the pressure exerted by the cuff of the endotracheal tube. As you can see here, if the cuff pressure is too high, it's going to lead to ischemia of the tracheal mucosa. This will then lead to sloughing off of the mucosa. And because the blood supply to cartilage generally is not great, once you have any kind of scarring going on, it will result in a circumferential kind of stenosis. And as you know, scar is very, very hard to treat. In problematic areas like the trachea, it is a very slow and tedious process to try to get these airways to reopen. And this is just a sagittal CT neck view of a patient who has total subglottic stenosis from prolonged intubation from COVID. And the only way she can breathe now is through a trach. And unfortunately, a severe injury like this cannot be reversed through any kind of surgical debridement. Now, if the stenosis wasn't so severe, if it's a low grade to moderate grade stenosis, I can actually treat these patients with in-office steroid injections and never even have to take them to the OR. So here's a video of an awake patient whom I had numb already with some transcervical injection of lidocaine, and now a needle's entering, and I'm targeting the web. You can see how there's a little divot already from a previous Kenalog injection, so it is working. So just by doing this a bunch of times, these patients can have good control of their tracheal stenosis. Now, if the stenosis was more severe, then I do take these patients to the operating room to do what's called lasering of subglottic or tracheal stenosis plus balloon dilation. Here, the patient has just had the balloon dilation. I'm withdrawing the balloon, and then I'm looking at the stenosis again, and the stenosis now is much more patent. And the char you see anteriorly in the trachea, that's from the lasering. Okay. So after surveying the entire upper airway, sometimes I find nothing wrong. And the patient has already come to me with a negative pulmonary workup. And then sometimes these patients already have a trach in place, and yet they're very short of breath. So that leads to what's called the long hauler syndrome, where there's no obvious radiographic sign as to what's accounting for their shortness of breath. There's really no airway stenosis. And this just highlights how much we don't know yet about the sequelae of this illness. And that's why we have this multidisciplinary team set up here in Banner. Now I want to shift gear and talk about COVID tracheostomy. Tracheostomies are one of those most commonly performed procedures in ENT, and I take care of a lot of trach patients. Normally it's done 2 weeks after intubation just to minimize the risk of subglottic and tracheal stenosis. There's no hard data, but that's kind of what our field has come to do. Just because if you do it too early, maybe the patient could be weaned off the ventilator. But if you do it too much time after the initial intubation, then obviously there could be all kinds of complications. However, with the pandemic, it introduced a lot of dilemmas. Initially, we did not want to do it because we thought by converting a patient from a closed circuit to an open circuit, which is what a tracheostomy is, then it will widely spread the virus and endanger everyone around the infected patient. In addition, anyone who was intubated and ventilated early in the pandemic had a very, very high mortality rate of 80%. Now, things began to change as we gained a better understanding of the virus. We knew that 2 weeks after the initial contraction of the virus, even if the patient was being tested positive on COVID testing, even if they were shedding the virus, they were not being actively infectious. In addition, the mortality rate for vented patients no longer was so high as we improve our ventilator management. And then we learned from colleagues from all over the country that trachs could be done safely without excessive risk to the operative team. So here you can see how our trach team, made up of 4 ENT surgeons, worked seamlessly together, wearing PAPRs. They were hampered by the fact that they couldn't wear any headlights, which we depend on in our field because we're always looking through small holes. But somehow these very highly skilled head and neck surgeons as well as a facial plastic surgeon and a sinus surgeon, they work very well together, and they perform trachs on some of the very challenging patients. Some were obese, as you can imagine, some with very short necks, and yet with all these barriers in mind, they perform over 50 COVID trachs during the surge, multiple surges, and they did it safely. So the very first COVID trach was done, I think, on May 3rd, and this really represented a turning point in how we began to manage this disease. And instead of delaying these tracheostomies, we started to do them early in order to wean them from the ventilator. And I'm actually seeing more and more patients who have been trached now post-COVID, and it is indeed a very, very challenging patient population because their airway stenosis could be very severe and can be multi-level, especially the ones from early on in the pandemic. Oftentimes they were intubated for 30 days or even longer. These were lengths of times that we were not used to seeing. And for these patients, they all want to get rid of their trachs, but they remain very, very short of breath, even with a trach in place. And maybe it's because of all the underlying lung parenchymal injuries. So these patients need to have a serious talk about how they'll have to be living with their trachs forever. It's not something that they'd like to hear. And anyone with a trach obviously will need to be under the care of an otolaryngologist for trach changes, and also just for all the possible infections or sometimes granulation tissue that could present. So in conclusion, shortness of breath after COVID is common, and these patients need a thorough survey of the airway. The etiology could involve anywhere from the glottis to the lung parenchyma, and it really requires a multidisciplinary approach to their care, including specialties from ENT, pulmonology, and speech pathology. Thank you very much for your attention.